Hello, Dr. Camp and class. Today I am going to be talking about our scenario, our case study for unit number 3. We were presented with a 78-year-old male who presented to the ED from a skilled nursing facility with shortness of breath and chest pain. He has a very extensive cardiac history. He declined rapidly in the ICU and was admitted for a non-STEMI and septic shock. He was intubated, on a heparin drip, the whole 9 yards. So, first question is that they want us to do a problem representation of this scenario. So, a problem representation is a one-liner statement used to summarize a patient's case on rounds and notes or when calling consults or inversions of the problem representation. So this one-liner should clearly state who is the patient, what is the temporal pattern of illness, whether it's acute, subacute, or chronic, and tempo, whether it's stable, unstable, resolving, intermittent. And lastly, it should say what is the clinical syndrome. So what are the key signs and symptoms? So the problem representation that I came up with was a 78-year-old male with extensive cardiac history, which presents to the ED with acute shortness of breath and chest pain and SIRS. So according to the last letter of my last name, I was given option A, which is that I'm the primary service for this patient, and my focus is on managing the hemodynamics of the patient. So my plan for this patient would be, of course, to consult pulmonary critical care for sedation and analgesics management. Also consult infectious disease for antibiotic and antifungal management. I would also consult nephrology for his chronic kidney disease and management. He does have his sodium at 130, his potassium at 3.3, BUN 34, and creatinine at 2.3. So that definitely needs to be managed by a nephrologist. That way they can make the decision whether this patient needs dialysis or not. I would also consult cardiothoracic surgery for a pulsable CABG post the non-STEMI, especially with the history of CAD. Usually cardiothoracic surgery would order a cardiac cath just for the definitive diagnosis and to check the severity of the CAD. So that way they know if it's one vessel, two vessels, three vessels that are damaged and need to be fixed. I know this because currently my clinical rotation is in cardiothoracic surgery, and I deal with these patients on a daily basis, and this is the protocol that hospital goes with. I would start this patient on a norepinephrine drip at 14 micrograms per minute. The formula that I used was 0.1 micrograms per kilogram per minute. So since the patient weighs 146 kilos, that's how I got the 14 micrograms. So norepinephrine is the most commonly used vasopressor, and it is the recommended first-line agent by the Surviving Sepsis Campaign experts for patients with septic shock. The goal of vasopressors in this situation is to increase systemic vascular resistance by direct constriction of the vessels, and that way it helps bring up that low blood pressure. I would also order a stat echo to confirm that ejection fraction of 25% and to check if it stayed the same or gotten worse. I would replace the potassium with 40 milliequivalents IV at 10 milliequivalents per hour because that potassium was low at 3.3. I would also give Oframev 1 gram IV for that fever of 102.3. We do want to bring that fever down until those antibiotics start working and get this infection under control. I also would draw a type and screen and a type and cross for a possible blood transfusion. He did have a hemoglobin of 7 when he was admitted. And I would also draw a stat CBC just to confirm that 7 is correct. Maybe they drew the labs too quickly in the ED and something, the blood either hemolyzed or was too diluted. I want to make sure that 7 is correct. That way we can transfuse accordingly. I would also place the patient on a heparin drip protocol per the facility. Every facility is different. I would draw a CBC and BMP in the morning just to see how that potassium is after I replaced it, as well how the labs look in the morning. I would do a chest x-ray in the morning as well. That patient did have an infiltrate in the lungs, so I want to see how that looks the next day. I would want to confirm home medications just to make sure that I have him on the correct medications for the correct disease processes. He does have CAD, diabetes. All these things are very important. Lastly, I would place the patient on core measure medications post the non-STEMI. Those core medications are aspirin, atorvastatin, and metoprolol. So according to Lynn, Holman, and Jameson, patients post non-STEMI should be placed on an antiplatelet agent, a beta blocker, and a statin. Very important for these patients post STEMI, just to prevent any further damage of the heart. Well, thank you very much for listening to my discussion. I hope you enjoyed it. Have a good day.